Hi, welcome everybody to Pediatric Grand Rounds, people here in the audience and people on Zoom. Dr. Rafi is not, Dr. Rafi, Dr. Hirsch, gosh, my brain. Dr. Hirsch is not able to join us today, so it's my honor to welcome everybody and also to introduce our speaker, who I've known for a long time, but it's actually really interesting. When you get someone's bio, you go like, oh, did I know that? Maybe I didn't. Anyway, we have a really fantastic speaker today, Dr. Matt Pentel, who actually has a remarkable bio. You look at what he's done. He worked at the Health Policy Center at Urban Institute before attending the UC Berkeley UCSF Joint Medical Program for medical school. And for those of you who don't know that program, it's actually a very interesting combined program. One of our own graduates from the pediatric residency program, Jyoti Marpan, now is the director of that program, where people can earn an MD and a master's in health and medical sciences, focusing on social epidemiology in the case of Dr. Pantel. At the JMP program, he became interested in social epidemiology and how social factors influence health outcomes, working with Dr. Nancy Adler, Dr. Lansomi, and Dr. Elisa Epel. As a medical student, he also completed a fellowship in the clinical research training program at the NIH, where his work focused on biomarkers of socioeconomic status. He completed his residency in pediatrics and was chief resident here at UCSF, during which time he became interested in interventions to address patient social needs, working with Dr. Laura Gottlieb. Currently, he's an associate professor at UCSF, where his research is conducted with the Center for Health and Community and the Social Interventions Research and Evaluation Network. His work focuses on implementing social drivers of health screening and interventions in clinical settings, the utility of incorporating social information into clinical decision-making, social informatics, and biological manifestations of social stressors. Clinically, Dr. Pantel works as a pediatric hospitalist at UCSF Benioff Children's Hospital here at Mission Bay and Washington Hospital in Fremont. He also, this I didn't know, runs the tattoo removal clinic at Zuckerberg San Francisco General Hospital. And then the things that he didn't include in his bio, but I think people really should know, is that he's a phenomenal teacher. He comes to clinical reasoning with a mini boombox on which he plays sort of different songs and soundtracks to liven up the suspenseful stories that he discusses during clinical reasoning. And he is also an outstanding mentor, mentoring both trainees and junior faculty in their research efforts. And it shouldn't be a surprise that he is therefore a recipient of a mentoring award of the UCSF Academy of Medical Educators. So really someone that we are really proud and glad to have in our community. And he's going to talk to us today. But before we invite him to the stage, I want to make sure that we do a quick land acknowledgement, because we are on the land of the Ramaytush Ohlone people. And I sometimes struggle with land acknowledgement because it oftentimes feels very much like, okay, we're now doing this. So it's like becomes a little tokenistic. But I think in particularly in the introduction of Dr. Pantel and his work, this awareness of where we sit and where we stand in this moment in time, and what our responsibility is to create community and to actually honor that sense of community is something that I really want to pause and think about, so that we look at this work in that light, and that we all reflect together on how each of us can contribute to that overall notion of being good stewards, not just of the land, but of the principles that the original occupants of this land brought forward. All right, I've talked enough. Dr. Patel. Listen to me, but
okay. Thanks, Andrea. I forgot my boombox, so I'm sorry if it's not as lively per usual. Okay, let's see. You got it.
Yeah.
There we go. There we go. Just fake out. All right. thank you everybody for being here today. When I'll talk about titles integrating social and medical care in the pediatric inpatient setting, practices, policies, and precautions. And yes, thanks everybody for coming. For those on the web, you can't see it, but now I know what Taylor Swift feels like. It's totally packed. They had to bring in multiple rows. So you have to be here to see it.
Probably standing up and waving.
Oh, yeah. Exactly. I feel it. And I have no competing interests to declare. I've been looking for years at ways to make money off of helping with social drivers of health. Turns out it's not really out there. So I'm looking to add to this slide. So please tell your friends. I would love to fill it up. All right. So social drivers or determinants of health. I want to talk about relationships between them and health outcomes. And just to start with some definitions so we're on the same page. So we're now, a lot of people have heard of social determinants of health. We're moving around sort of in the literature to saying social drivers is the preferred term, just to make it so that the term isn't as deterministic as possible. If you have social risks that you've been exposed to, you're not necessarily destined to have poor health outcomes. So these social drivers of health are, the CDC definition is the conditions which people are born, grow, work, live, and age in the wider set of forces and systems shaping the conditions of daily life. Social risk factors are more like the adverse social drivers of health. So a social driver of health is social support, but social support isn't going to put you at risk of adverse health outcomes. Social isolation will. So when we say social risk factors, that's really the adverse social drivers of health. And then social needs we talk about are when families would like help addressing their social risk factors. So sometimes we screen patients for social risk factors. We ask if they want help addressing them, and they say no. And so we would say that they have a social risk, but not necessarily a social need. And just for some sort of the context of the field that's been going on for a long time, but some of the landmark studies. One is the Whitehall study that Michael Marmot conducted. He's an epidemiologist. I think he's still there at University College of London, but UC Pride. He got his master's here at UC Berkeley, where he worked with Len Syme, another UC Berkeley social epidemiologist. And the White House study was really one of the landmark studies in social drivers of health, because it sort of helped contribute to this idea of a social gradient, where it's not just sort of the having social risk factors, but sort of that there is a stepwise association between how much socioeconomic status or how much social positive factors you have, and the association with positive health outcomes. So what you see here is this is all British civil servants. They all have the same health insurance and access to healthcare, theoretically, same insurance plan, right? And what it shows is that as people sort of go, have decreased power in terms of their employment, occupational status, in terms of pay or whatever, whatever grade they are, it increases the risk of many health outcomes they looked at. So the social gradient has been replicated in almost every outcome. And a lot of the work has been done here at UCSF with my mentor, Dr. Nancy Adler, who for her entire career has sort of shown relationships between social drivers of health and health outcomes. This looking at kids in particular, where you see as socioeconomic status increases, there is a decrease in the prevalence of numerous pediatric health outcomes, chronic condition, asthma, ear disease. And you can see this is from 2007. I purposefully keep it there because it's just everything has been replicated and this has stayed stable for many years. And it's not just individual social risk factors, but cumulative social adversity. So the more social risk factors you have, we tend to see the more higher risk of adverse health outcomes among children. Looking at this as just general poor health and poor dentition and socio-emotional problems. So yeah, that's the idea of sort of this cumulative social adversity. And we're starting to learn more about the biological mechanisms, which I'll talk more about some conceptual frameworks, but a study we just recently did involving patients at San Francisco General at 6M, and looking at sort of biomarkers of inflammation and steroids, and actually a bunch of other biomarkers, endocannabinoids and epigenetic aging. But we found that cumulative social adversity in particular is associated with increased likelihood or increased levels of all the interleukins we looked at, IL-1 beta, IL-6, IL-8, and also TNF alpha, as well as cortisol, had sort of the beginnings of a U-shaped curve. So trying to understand some of these mechanisms is sort of what we're doing now. Okay, brace yourself for this one. I do a lot of these, so we'll walk through this one slowly and then they'll go quickly. So this is sort of time to event analysis or Kaplan-Meier curves. So what you see on the y-axis of these here is think of patients that are hospitalized and then they're being discharged, and the y-axis is the percent of them that have not been readmitted. So when they're discharged, 100% of them haven't been readmitted because they're leaving. Great. Then as you go out by days and days, it's the percentage of them that are not readmitted. So in other words, if the curve is going down quickly, you're being readmitted more quickly. So the percentage of people not readmitted is lower, i.e. the percentage of people being readmitted is higher. So this is kind of like a survival curve, right? So if you look at here, looking at social risk factors, they are related to the inpatient setting. So patients with documentation of social risk factors are readmitted more quickly than those without social risk factors. And you can see here, looking at neighborhood income, there's sort of the classic social gradient, with those with the lowest quartile of income being readmitted more quickly in the blue versus those with the highest in the black, and sort of the gradient going down there. That's the kids inpatient database. Yeah, sorry about that. Lots of people here are doing work on this. So Dr. Kayla Carvonen, who's a fellow, just finishing fellowship, has done work looking at associations between structural racism and many adverse health outcomes related to hospitalization, including readmission, post-discharge death, as well as frequent acute care visits. Dr. Danny Soulsby, our assistant professor in the Peds Rheumatology Department, has looked at among children living with lupus. This is also in the kids data set, kids inpatient database, so a national data set, has found length of stay is longer for those with higher social risk factors. I see Erica there too. So lots of people doing this type of work sitting right next to you. And then there hasn't been as much of this work done in the inpatient setting. So we don't know as much about the prevalence. There have been single center studies looking at the prevalence of social risk factors among hospitalized children. But we tried to sort of do this recently in the National Survey of Children's Health, which is a national survey of that's nationally weighted to get sort of population estimates. This year was 2020 was 42,000. And what you could see is in blue is kids that have not been hospitalized in the last year, and red is those that have been hospitalized in the last year. And you can see the percentage of social risk factors among all of them. And you could see those that were recently hospitalized with the asterisk is significance. You can see recently hospitalized children have significantly higher rates of financial strain, food insecurity, child care issue, problem paying medical bills, any risk, and then 4 or more risks. And then interestingly, emotional support was actually the opposite. Kids who are recently hospitalized, their caregivers report having more emotional support or less likely to lack emotional support. So we're sort of hypothesizing about some of the community you can have if you've recently had a child hospitalized. So talking about the approach to integrating social and medical care in a healthcare setting, I want to talk about this National Academies of Sciences, Engineering, and Medicine report that came out in 2019 that was headed by Dr. Kirsten Bibbins Domingo, who was also UCSF, head of Epi Biostats. I think she's still technically part of them, but is now the editor of JAMA. So she led this group, and they came up with what's called the 5 A's framework of awareness, adjustment, assistance, alignment, and advocacy as ways to incorporate social and medical care, particularly in healthcare settings. All right, I promise this is probably the most dense slide, but I think it's important. And if anybody wants them, it'll be there for reference. But these are sort of examples of the 5 A's framework that then we'll go through. So the first activity is awareness. So this is activities identifying social risk. So this is kind of like screening. So you can't be aware of someone's social risk unless you ask about it. So an example related to transportation would be screening for transportation needs. Adjustment is activities that focus on altering care based on social risks present. Okay, so if you identify someone who has transportation needs, you can change their follow-up visit to be a telehealth visit if they have a telehealth capability instead of making them come in person, because that would get around the fact that they have this transportation need. Assistance is the typical thing people think about, which is activities that address the social risk directly. So if there's transportation needs, give them a Muni token, give them access to transportation. So that's what we typically think of if you're going to screen to do, is to provide this direct sort of thing to address the social need. But that's what part of this framework is showing, is the other things you can do in response to identifying these needs, besides directly addressing them if you don't have the resources. And then alignment is basically understanding and working with community organizations to sort of help facilitate synergies in the community to address social needs. So this would be investing in community ride sharing so that we can get some service to get patients who can't get transportation to come here. And then advocacy is sort of using all of this to advocate at sort of the policy level. So if there are people if there's a neighborhood where everybody seems to have transportation difficulty, let's advocate for Muni to have a route to go there and show them the data that we have all of these patients who can't get here. Okay. The most dense slide. Okay, so it's talking about awareness, first of all, that first thing, identifying social risks. There's lots of endorsements for screening for social drivers of health now. I keep having to add this, and it's annoying because then I have to move stuff around again. But it started, with a lot of the pediatric organizations, the American Academy of Pediatrics, then we have the Children's Hospital Association. Adults are catching up a little bit. They've got the ACP and the American Hospital Association having some endorsements and support for screening. Not that we should do things based on this, but it does turn some ears. The U.S. News and World Report is now awarding points for SDOH screening. All right, I lied. Another dense slide, but I think bear with me. I think it's good. And I made it, so I feel strongly about it, So other standard setting organizations are now endorsing screening for, and in some cases addressing social needs. So the big thing to look at here, so CMS is endorsing doing this for patients 18 years and older. The NCQA, National Committee for Quality Assurance, is also endorsing it in terms of HEDIS measure and sort of indicators of quality. And the Joint Commission is also endorsing it. So all you really have to look at is the middle, is the overlap of all of them, is that all of them are endorsing this for the inpatient setting, inpatient, screening for food, housing, and transportation. Some of them are additionally endorsing screening for utilities and IPV. Joint Commission, I actually really like. They don't say which ones you have to do. They say sort of figure out ones that are relevant and do it. So, that's why you've got that weird yellow thing there. And the Joint Commission is also saying that people are required to provide information about community resources. And NCQA is saying that there should be an intervention on or up to 30 days after the initial positive screen. So this all sort of went into place this year. Some of the endorsements for follow-up are really going into place next year. The penalty is, might not be as severe as you might think. It's not necessarily reimbursement, but these things are being published as quality indicators. And so we'll see what it does in terms of movement. But there's tons of committees working on this at UCSF. Okay, so we did a study to try to get a sense of what hospitals were doing, or we analyzed a study to see the American Hospital Association annual survey. This goes out to hospitals throughout the country. We tried to identify the children's hospitals in those in that data set by seeing which of them said that they primarily served populations of children. And so this is showing in 2020 what children's hospitals reported as things that they were screening for in the hospital setting. And so it ranges from a low of employment and income to a high of housing at 67.5%, but 80% were screening for at least one, and then it trails down, 58% were screening 5 or more, 34% were screening all. Now, this seems high to me. I'll just put out there. The way these surveys are done, all right, is they send it to the hospital, one of the people who's the contact point there, who's a hospital administrator, and they ask them to fill it out to the best of their ability. So we really don't know. This could be answering saying we screen a couple of people to we screen 100%. We don't really know, the penetrance, if you will, of like how many people are screened. But this is hospitals reporting that they do some sort of screening related to these social risk factors. And then Sahil Sandhu also took this data set and we looked at it, and he was leading to look at what hospitals, and this is among adults as well, what hospitals are more likely to be doing this screening. And he found a couple of things, is that rural hospitals are actually less likely. So if in terms of targeting resources and support, trying to target them, and that, these alternative payment models, so hospitals that were participating in accountable care organizations or bundled payment or patient-centered medical home, they were more likely at the bottom right there to be having screening for all 5 social drivers of health that CMS has endorsed. And in terms of what patients think about this, my colleague Amelia DeMarcus led a survey that was done in 10 health systems throughout the country, including the Parnassus ED was one of them. And they asked people in the emergency department and primary care, how do you feel about being asked about these? Is it appropriate? And you can see there, I sort of look at, the far right too, because this is a Likert scale. So the somewhat inappropriate and very inappropriate are the far right. So those are, less than 10%, about, between 6 to 8% of patients saying they feel that it's inappropriate. The rest were sort of neutral or felt it was appropriate. So it is pretty good in terms of something that we think patients feel okay about based on this study. In terms of who is screening right now, what we did is, this is a survey we sent out to the pediatric research in the inpatient setting. So this is a bunch of children's hospitals in a research network throughout the country. And what we see here, of the 43 that answered this question, I think we emailed like 90. So not the best for this question. Of course, this is only among those hospitals that are screening. We asked them, who is asking this, and it's not mutually exclusive categories. And so in the inpatient setting, nurses are the most commonly asking, 71%, followed by residents, 29%, social workers, attendings, other. But really, nurses are the ones that came out as being sort of the frontline screeners in pediatric hospitals right now. And there was a study done with patients, again, very rare that we've seen studies with caregivers of pediatric inpatients, but this is one done by Tamara Gale in 2023 in Children's National, asking caregivers of pediatric patients that are hospitalized, when's the best time to be asked? And, most of them you could see in the emergency department, only a few said, some said when you arrive, 18%, 20% said not right away, but on the first day. 30% is anytime other than the first day, and then a quarter said anytime is okay. So I think, to me, this sort of says, we're looking at 70% feel it's okay the first day, because I think a lot of hospitals are talking about pushing and having it during, an H&P, during the nursing admission questionnaire. So it's about 2/3. It's not perfect. So it's something to consider, if we can figure out ways to ask and, have some sort of reminder for the second day that might be preferential for some patients who are not ready for that. And you can understand with acuity why that might be the case. We also asked them in this prize survey, so 60 children's hospitals answered this, about this is kind of confusing, but what are sort of the top 3 barriers and facilitators to doing screening? And you can see in blue is things that people identified as big barriers. So hospital staffing and time were the big barriers that people identified for screening. But then facilitators, some good news, like the, hospital culture was number 1, was the highest. So I do think a lot of hospitals, or at least children's hospitals, feel that this is important. And then you see informatics technology, which we'll talk about a little bit later. There are a lot of screening modules coming up to help facilitate this. So that was the second most common facilitator for screening.
Hey, Matt.
Yeah. Oh yeah, sorry, to cut off. That was basically connections with ties with community-based organizations. So a lot of people saw that. Well, I guess only 8% saw it as a top barrier, and almost a quarter saw it as a facilitator. So if they have sort of working with community-based organizations, or the available community-based organizations, it's not quite specific, but it's sort of like the ability to work with them was a facilitator. Yeah. Okay. So related to screening, so Dr. Salma Dali, who's our second year hospitalist fellow, is doing a study right now at both Mission Bay at the Med-Surg ward and at the Transitional Care Unit, and also at Oakland at the Med-Surg ward, asking parents a lot about this, about screening preferences for social drivers of health, and exploring things from, experiences related to discrimination, and whether it should go in the EHR and when it should be done. And we're just in the middle of the analysis of that. But these are just a couple of quotes that, not all exhaustive or really all encompassing or representative, but just a few that sort of reflect things that we've heard a couple of times. So first one is, everybody should get it, because I think you wouldn't accept it if it wasn't offered to me, right? I wouldn't be asking for it, I guess, is what I'm saying. So we heard a lot of, when asking people, do you think it's appropriate to ask? And even people who said, they don't need it, they said, I think it's important to ask, because, you wouldn't necessarily bring it up. And then also talking about some of the hesitation. So someone said it's something that most belongs between the doctor and the patient if necessary. not between the file and anyone who has access to it. So it's interesting asking a lot of patients about, do you feel like it's okay to bring up and to screen? A lot of them will say yes, but then if you ask about what's done with it, there is some hesitation, which we'll talk about a little bit more. All right, 1A down, 4 to go, but the rest will go more quickly. So adjustment. All right, so adjustment, I think is the most interesting one to talk about, because I think this is things that all the clinicians in the room, we all do, and we just don't write down that we're doing because it's just sort of like what we do automatically. So to start at the top, Laura Gottlieb will and Hugh Alderwick wrote a paper about sort of the difference between these two terms. So social needs targeted care we talk about as kind of like assistance. So this is offering resources that directly address the social need. So someone has food insecurity, you give them a voucher, you give them a bag of food, you sign them up with WIC, you try to mitigate that sort of social risk that they've identified they want help with. The social needs informed care is sort of the adjustment. So this is practicing with awareness of how social risks may affect the care. So, right, so not prescribing a medication that needs to be taken with food if someone has food insecurity, right? And we talked about that, not doing a phone follow-up for someone who has transportation needs, or doing all of the, doing all the subspecialist visits on the same day for someone who has transportation needs. So these are things that I bring up because sometimes, and it might be out of our hands whether or not we're screening or not, wherever we're working, but that information, even if you don't have a resource to address it, might be useful in care planning to ensure that somebody sort of has the best medical outcome that they can have, right? So yeah, social needs informed care or adjustment. Asking this was part of our pilot on MedSurg when we're doing the rollout of screening. We asked clinicians, so this was nurses, social workers, residents, attendings, I review information regarding patients' SDOH from the chart. So it's kind of a bell curve. This was about a year and a half ago, but skewed to the left a little bit and showing more that people say I use information about SDOH in medical decisions and care planning. And again, that's sort of that adjustment when you know about these things. The Office of the National Coordinator for Health Information Technology, they published something last year using that same data set I was talking about, the National American Hospital Association annual survey in 2022. They added some questions more about EHRs and using data. And in that, this was 2,100 hospitals, right, adult and children. They said 72% said that the SDOH data they collect, they use to inform discharge planning. 67% said they used it to inform clinical decision making. Again, this is somebody speaking for the entirety of the hospital. There's probably some variation, but hopefully it's a signal that it is being used for some people some of the time. In terms of how clinicians can adjust clinical care, so in addition, and I'll talk about another study, we're interviewing staff at hospitals about their preferences and thoughts on and experiences with doing this work. And, this is one talking about how they adjust clinical care, saying if it could really make a big difference, like if a med was prescribed, this is a caregiver, I'm sorry, not yet. Med was prescribed and, for example, had the same effects, but one was $0 copay and one was a $25 copay. I think that those things would be really appropriate to use in determining what would be best or suitable for that family and their needs. So this is, again, a caregiver saying this. And and in some of our groups, I'll just say, for example, the TCUP SDOH task force, they've identified financial strain as a really important thing that they want to screen about, partially for this and medications and trying to get, these complicated medications going and the prior auth so that they have enough time to get them. All right, here we are, clinicians. How can clinicians adjust clinical care? So Antho Diep-Rosas, who's a second-year med student. He's leading some interviews with Department of Public Health clinicians about their screening experiences. And he's found, for example, when talking about unstable housing and how clinicians adjust care, they brought up, when I know a patient has unstable housing, I'll collect multiple addresses. So we know how hard it is to fix housing in San Francisco, but these are things that we can do to try to tailor their care. So I also collect samples the same day at a clinic if we know that they have unstable housing, and maybe next week they'll be in the peninsula and they're not going to be here because they're couch surfing because they're staying at different places. So, and then Rachel Kim is our amazing first year pediatrics resident, is doing a project interviewing staff about this. And here's one of the quotes that's come up so far. So I do know, and I try to be mindful, if there's a situation where the family is pretty concerned about the hospital bill and there's no guarantee that at the end of the day a bill is going to be covered if folks have high deductibles or things like that. It's just being really mindful about what kinds of things we're ordering and why, and making sure that there's a conversation with the family. So again, think these are things that we all do. We just like, I think we're used to saying like, what can we do about this once we identify it, which is a totally valuable thing to bring up. But I think some of the stuff that we're doing as clinicians, we just sort of don't even realize because we're so used to sort of doing this tailoring. So again, examples of adjustment. Okay, and this is kind of getting into the social informatics. So we're using EHRs to kind of see what people do with social information, how they use it to address social needs, looking at some things that clinicians, check on and document. So this is, all right, I told you guys to get used to these curves, right? So this is looking at UCSF hospitalizations between adults and kids between 2019 and 2020. And what we see here is that clinicians, what we did is looked at how many clinicians looked at social information in the EHR, like clicked on a social work note, went to the social history page and did some editing. So trying to do this active engagement with the social history parts of the note, not the best measure, kind of just a signal. And what we see here is that in blue are the people that didn't click on any of the social information that was there. And the red is the people that did. So you could see the people in blue are being readmitted at much or quicker rates and significant than those in red, which our hypothesis is that if you know the social situation and you engage with that information, you can tailor this care with adjustment and assistance more likely than if you don't engage with this information. We obviously have to prove that and show it, but this is kind of just the big, helicopter view of it, maybe airplane view higher up. But yeah. Okay. 2 out of 5 A's down. Assistance. So the good news is, providing social resources to patients is actually good for us that work in this. So studies have shown, again, Amelia and I have done some studies and she's done some with other colleagues showing that, capacity to address patient social needs is actually associated with higher job satisfaction among clinicians, better perceived quality of care, and less burnout. So that's the ability to do this. And what this is looking at is back to that American Hospital Association survey, again, of just children's hospitals in 2020. We looked at what they were screening for. This is hospitals saying they actually have strategies in place to address social risks when they're identified. So again, sort of some variation between 44% for employment and income, and then 71.3% having strategies to address social isolation. But you see almost 96% of them. So remember, before it was 80% were screening, but here 96% have something in place to address some sort of social need. So it was interesting to see that it was higher here. And again, it goes down the more you look at that are in place. Again, Sahil Sandhu's analysis, you could see here, rural hospitals less likely to have social risk strategies in place, these being the social risk strategies for the 5 CMS mandates. And again, these alternative payment models in the bottom right, more likely to have social risk strategies in place. Okay, so what are people doing when they identify this? I know we're hopping a lot of surveys. The data is, not available everywhere. So this is that prize study again of children's hospitals, 71 saying, once patients screen, do you have something in place to make referrals? And for in-hospital services, about half of them have things in place to be done at a systematic basis, and they do it. Others, 43% do it on an ad hoc basis. For out-of-hospital services, sort of lower, right? So 30% of hospitals said that they had something to refer patients to on a systematic basis, and they did so on a systematic basis. Almost 2/3 saying they do it on an ad hoc basis. So less sort of infrastructure or consistency when you're talking about referrals to things outside of the hospital. In terms of what hospitals with whom they're working with, these are sort of the percentages of hospitals with the American Hospital Association survey, children's hospitals. These are the sort of the community-based organizations, the percentages they're working with. So, ranging from a low of 27% working with local businesses to, 62% working with what we call other nonprofits that are not the ones we've listed here, with K through 12 schools at about 58%. And then in terms of how hospitals are providing referrals, this is again back to the prize study, 60 children's hospitals. A little over half are giving a handout with information, and then 93% inpatient are doing referrals to an in-house social worker. So that's what's set up once they're positive. Something to think about in terms of work resources that we have. 15% have inpatient navigators, which really the literature supports is actually the most evidence-based intervention to address social needs, but only about 15% of children's hospitals have them, and then various different forms of other things. 32% is these online social referral platforms where you make a referral to a CBO, a community-based organization. I'll talk more about those, but it's a third of hospitals are saying that they're using those now. And then once you make a referral, do we follow up? You can see in blue, 5.3%, dark blue, sorry, it was the Excel's automatic colors. 5% are doing following up on referrals on a systematic basis. 26% are following up on an ad hoc basis. This is my favorite. 25% don't know, which is true. So a lot of people just don't know what's going on. And then 40% say that they're not really following up after these referrals are made. This is just to highlight some of the community-based referral platforms that are being used. Dr. Dana Long, our colleague at BCH Oakland, has created a referral platform called Find Connect, where you can refer patients to community-based organizations, has some great maps you can use. And when you're on the Oakland side, anybody who's working here, I encourage you to look for the Find Connect sort of interface and Epic. And then UCSF, as well as the other UCs and UCOP with an RFP, purchased Find Help, so another referral platform. So this is where you put in the zip code and you look for the patient, and then you can provide actually a two-way referral where you can refer them to something, and then the CBO, if they onboard with it, which is free, but they still have to learn it, can then write back, the patient, services were given and that type of thing. So you can actually see a closed loop referral. Could do a whole talk about if these work and barriers, but we don't have time. But these are becoming more and more purchased. Unitas is another common one. You might have heard this used to be called Aunt Bertha. So these are being used more and more in hospitals, especially now with these things from CMS and the Joint Commission to show that you've actually addressed something. I'll put quotes because these don't necessarily mean anything happens, but another grand rounds. So we did a study I'll talk more about where we were interviewing CBOs about this. And this is a staff member of a San Francisco CBO talking about the potential of using these platforms, saying what they need is definitely training, education, just like using an EHR. There's always a little bit of growing pain, but personally, I'm a big fan. And I think most people in my position would be okay with it. But I can imagine in other CBOs, it might be a little more difficult just because you're not used to that kind of platform. Because again, I miss having that ease of access because that's how my old jobs were. But yeah, some people, it might be a little overwhelming. And, in these interviews, we found that a lot of people working at CBOs were like, yeah, there's actually big benefits to using these platforms and showing how many, communicating with healthcare systems. But like, you need to sort of like invest in us learning them. You can't just say we have it now and please use it. Okay, and this is going to some of the navigator literature we talked about. So another one of these graphs. So we know that addressing social needs is related to improved health and reduced hospitalizations for relevance to this talk. So this is studies that were done at San Francisco General and BCH Oakland outpatient, where families were randomized to receive a resource sheet, which was called the control because we didn't want them to have nothing if we screened them. So they had a resource sheet that was generic, or they had a navigator who basically walked through the resource sheet with them, talked about what was most important to them, called them or texted them over the next few weeks to say, hey, did you make it to, this community-based organization? If not, how can I help get you there? So it's kind of still a light touch, but a more intense touch intervention. And you can see on the left there is looking at time to hospitalization. And so you can see that those with the navigator on top were being hospitalized less quickly than those that had just the handout. Then we published in another journal and they wanted to flip it. So this is a different cohort showing the same thing, except it's going up. This is probably easier actually intuitively to see, but the same result was sort of shown that navigators actually improved health in one of them, and in both of them reduced hospitalization. In the second one, the health effect of self-rated or parent-rated health was not there. And they're doing more trials like this. Michelle Lopez, who's amazing, is usually at PAS from Houston, did a trial looking at, it's called We Care, which Arvin Garg, which people know, who does a lot of social drivers of health research in Boston. So basically they randomized people to either be screened for social drivers or be screened and have referrals, kind of more of the lighter touch intervention. And they found that 6 months later, they looked at enrollment in community resources, and they saw that intervention, about 57% were enrolled versus the control, 48%, which wasn't statistically significant. But so we're still trying to develop the evidence base for this. And I think part of what we're trying to do is figure out the best ways to measure it. So Siren, for those who don't know it, is the Social Interventions Research and Evaluation Network, which is sort of a think tank for this work at UCSF. It's headed by one of my mentors, Dr. Laura Gottlieb, a family medicine physician. It's great. Anybody interested in this? It has, monthly, what's the new evidence? It has webinars, it has grants, it has lots of cool stuff. But the leaders of Siren just recently, I think it's just published like this week or last week, sort of the social care logic model based on a lot of the studies that we've seen now. I know it's a little hard to read, but on the far left there in black is sort of what we're talking about, identifying unmet social risks. And the right is looking at improving health outcomes, decreasing unwanted healthcare utilization. And the pathways we talk about through getting there are, the top one is the one connecting patients with social resources and decreasing social risk. That's kind of what we're talking about with the biomarkers, like what is the stress reduction, mitigation of social risks, having a direct health benefit. Then in the middle there's connecting patients with social services navigators, improving emotional support potentially, which then improves health and decreases healthcare utilization. The third one is connecting patient with outpatient healthcare services, so increasing those to improve health. So the idea being, if you're addressing these social needs, people are more likely, let's say you address their transportation, they can get to their healthcare visits. So, and I think that's what people were initially thinking was happening instead of these other pathways. And then there's the healthcare team tailoring the care plan and to improve sort of disease self-management. So that's kind of the adjustment. And the interesting thing about the initial navigation study that that Laura led and Siren led, that I showed you, sort of led to reduced hospitalizations and improved health. When controlling for having social needs met, it did not account for it. So it wasn't necessarily that they met, food insecurity was addressed and then, things got better and that accounted for everything. It's something else. And we're finding more that this pathway is really not really linear. Is it something about the relationship, meaning now I really trust the healthcare system, I'm going to be able to come back? Is it something else? Is it trust building? So it's, that's why this model was kind of created to sort of try to suss out what some of these measurements are. So all that to say is, Dr. Lopez's trial, even though it didn't have statistical significance, depending on what we measure, probably can find some other meaningful change. Okay. Similar thing, looking at that prize study. Jana Leary, my colleague in Boston, is leading this analysis, looking at barriers to facilitators for making referrals. And similarly, you'll see that barriers, there are some things, hospital staffing and time, and also follow up with families was cited as a huge barrier, ability to do that. But facilitators, you can see hospital culture is again there. And then here, community-based organizations, the ties that you have with them was considered a facilitator. So things to highlight. Okay, so we do the last two A's together. Alignment and advocacy. All right, so bear with me. We'll look at the first one. What this is showing is with that American Hospital Association survey among children's hospitals, among those screening for housing, so the denominator is hospitals that screen for housing. Among those, looking at other things that they do, 77% of those hospitals have strategies in place to address housing. So 30% of them or whatever are not, they screen, but they don't have a strategy. 60% of them work with CBOs together to address those patient social risks. And then if you look at the green one is what I want to highlight, only 24% of them work with CBOs to do some sort of initiative in the community to address this. And that's the same for food. You see this drop off in transportation and with all three. So basically hospitals that screen for food, housing, and transportation, only 66% of them have strategies in place to address all of those. 50% of them work with CBOs to address them. And only 9% of them work with the CBOs on community initiatives related to this. I think the point I'm trying to get here is that hospitals are really right now seeming, work with CBOs related to, I think, the patients in front of them and the hospital walls, but they're not really engaging with community initiatives where these things are happening upstream. And hospitals have never really been incentivized to do that, even though hospital culture has been highlighted as a facilitator. But I think, when you're thinking about these policy incentives, they really go towards, most of them say you should screen, some of them say you should, provide some resources. None of them are really saying you really need to be working with community-based organizations, which is the key to actually having this stuff work. So, to investigate this, we interviewed staff from 33 community-based organizations in San Francisco, things related to partnering with healthcare systems in general to address patient social needs, and as specific as about EHRs. Did some thematic analysis, and we have some themes we derived, and we got some advice from them, which was really interesting. I wish I had more time to go through it today. One of the big themes was the benefits of CBO healthcare collaboration to address social needs. And so CBO staff members were saying, there are really lots of great things when we work together. This is an example saying during COVID, Friday, we'd come out with masks and hand sanitizers and gloves. We just do a lot of outreach, and their staff would come with us and then also talk to residents and set up appointments. And the residents would talk to them because our community health ambassadors were there saying, hey, I brought someone. One of my colleagues from the clinic or one of our partners from the clinic is here. Do you have anything you want to talk to them about? And I think that was perfect. The second theme they brought up was two-way communication and data sharing between CBOs and healthcare systems. And they talked about, the need for good communication and some of the barriers to doing this. And really, many of them talked about how they would really love to have a point person in the healthcare system, just equally as we think we would love to have a point person to talk in the CBOs. They would love someone who could call and say, hey, this person is experiencing mental health symptoms. Which clinic is best? How can I get them in? This is just someone saying that, to have a person that's designated that we can speak to, so that when we need to share information or we are referring clients to these health organizations, that we have the standard of who to speak to. They understand our system, our clients, and we understand their system in a real personal way. Someone who also can be more accountable to the referrals and the relationship. Also someone who can help us navigate their internal process. So again, and I don't get into much of it here, but a lot of the infrastructure for these referrals has been kind of one-way health systems referring to CBOs, but there's really a big desire from CBOs to work with healthcare systems and to make it a continued collaboration and two-way system. And then the third theme that came up was relationship building between CBOs and healthcare systems, which was huge. The take homes where you can't really build these referrals without really relationship building and sustained relationships. This is one interviewee saying, recognizing that CBOs are your ally or a team member, that we are on the ground frontline with pre-existing relationships with the marginalized communities that we serve. Once again, interacting with cultural humility, sensitivity, and respect, and coming in working with us as a partner versus delegating. Okay. We made it through the 5 A's. Thank you for staying. I just want to end a little bit talking of some of the ethical considerations and unintended consequences that we're exploring related to this work. Laura Gottlieb and Hugh Alderwick outlined this in a nice paper a few years ago about what some of the unintended consequences could be and how they could worsen healthcare inequities instead of trying to mitigate them. So I don't have answers to these. These are things we're exploring in some of our studies, but how does knowledge of social risk factors contribute to clinician bias? If you see this in the chart, is that going to lead you to make certain assumptions, whether either consciously or subconsciously? And how could documentation of social risk influence organizations accessing medical information, insurance companies, when this is documented? What does that do? What does it do now? What will it do in the future? Child protective services. If someone has food insecurity documented, who is more likely to have CPS called? Is it a certain population in terms of socioeconomic status or race? And how could this make, racism even more rampant, whether it's through implicit bias or explicit bias? Similarly, how could judgment be passed on different people with different socioeconomic status? So there's lots of discussion now about documentation and what should and should not be done. And then how does screening without offering resources affect patient trust? And I didn't put here, but also how does screening without offering resources lead to moral hazard? We've heard a lot from our frontline nurses when asking about this, that if you're asking us to ask these questions without something to offer them, that doesn't feel great, and it's not something I feel comfortable doing. So really, and again, a lot of these regulations don't delve into this. So just a caregiver, a hospitalized patient talking about some fears with this. And they said that their fear is, I guess, judgment, just because I've had so much of it in my life. And because I've seen people change how they treat you, based on their own biases and their own stories. So again, a lot of people that we interviewed and surveyed say they are okay talking about this, but they have concerns still. And this is someone saying, so I mean, I think it's great, but then I think kind of also, I think from a family's perspective, can create a false sense of hope, because you feel like you're going and you're connecting with the social worker, for example, but then you're not getting the support that you need, or this idea, especially for like families like myself. Amelia DeMarcus's study again asked about not only how appropriate is it to screen, but how is appropriate is it for this information to be included in the EHR? And you can see that 6 to 8%, inappropriateness moves up to, 19 to 20% in terms of putting it in the EHR. And this is pilot data. This is not, it's not, I wouldn't take it to the bank yet, but this is at our transitional care unit here at BCHSF. We've only thus far asked 19 families about their social risks, and very high levels of social risks in the transitional care unit, with a lot of patients living with complex medical complexity and chronic medical conditions. You could see almost all of them, except for education, said, I'm totally fine with you asking about this. When we ask them if they feel okay about it going in the EHR, they all drop by about a third, right? So this has really brought up questions about workflow. Is it better to, say screening was done and not document the answer, much as a lot of ACEs work is done, adverse childhood experiences? Is it better to just offer resources and say, hey, I don't care what you say? Some people that actually, deny social risks still want the resources, either because they don't want to say that they have social risks, or because they still want the resource, and the way it's asked is not the way that they would, know about it. So in summary, many professionals and professional organization and standard setting organizations are now endorsing screening. For the inpatient setting, it's particularly important because we do, deal with the populations that do have high levels of social risk factors. We know that addressing social needs can improve child health. It can reduce hospitalization. We're still trying to figure out the best and optimal ways to do it and the best mechanisms. Right now, there's all of those studies I showed were done before January 2024, so before these policies. So there has been wide variation in hospital screening and intervention practices, but we'll see how they change now. And I think what we've learned through doing all this work is that developing the best practices for doing it will require not only the patients, but the clinicians and the CBO staff input if we're going to get it right. And that whilst patients generally find it okay to be screened, we have to think about the ethical considerations. And wanted to end with a few things about CBOs, that they seem to be generally interested in data sharing. We're going to do a survey with hundreds of CBOs coming out. These were just qualitative studies thus far, not just, but these are qualitative studies. We can't, tell you an exact percentage of how many, but a lot of our qualitative interviews said that they were interested in data sharing and that they desire sustained communication and to be treated as equal partners in this work. And I'll end with a quote from someone at CBO that said, I think if I could tell health professionals one thing, it would be this: it takes a village, and what a health professional can give to a person is phenomenal, but what we give to a person as a collective is even greater. And then I would like to thank many people, especially Laura Gottlieb, Nancy Adler, and Jeff Feynman. It's my parents and my partner for supporting me through this work. And then Nancy Adler, who passed away a month ago. So yes, thank you. Yes, Meg.
Phenomenal work. Thank you so much. So I think for most of us, it was interesting to see the slide about the greater we engage in these kinds of conversations with patients, and the idea of operating in silos where we're just dealing with the quote physical issue, and that we're going to let the things flies in the face of reason about everything that we know about how to. And I just wonder what thought leaders like you are thinking about in terms of how we can get these things better integrated into our system without becoming another unfunded mandate we have to. We know lots of other examples of things that demonstrated to be great, which don't happen.
Yeah. Great. Totally. Great question for people who are on the Zoom. Yeah. Megan had said in the context of the slides talking about how addressing social needs is associated with sort of less burnout. And also in the setting of all of these sort of regulatory agencies endorsing this, how do we navigate this without it becoming an unfunded mandate? We know as clinicians is the right thing to do, but we have competing demands and also this is not coming with funding. So how do we navigate that? Does that capture it? Yeah. I think it's a very good question. I think they're trying to fund some stuff which is not doing great, right? So this is still going to be unfunded for a while. So I think really the best way until we do that is trying to figure out, I think just being very local and looking at what we can do with the resources we have. So like when I'm at tattoo removal clinic where it's me and the nurse I work with all the time versus Mission Bay where I've got 3 social workers for all the patients, and then versus at Washington Hospital where it's I think I would definitely approach it very differently for each of those and just try to think of what are the things with that I have there that I can do. And that's why for both MedSurg and the teacup, we're developing workflows, but they kind of look very different because we're kind of like, all right, in here we do this. So maybe we can screen everybody here and the way that we'll respond is with this because we have this resource versus at San Francisco General where there's health advocates. I'm like, well, this is actually somewhat easier because I have so I think until we could do it, trying to figure out what's the best we can do with the resources we have. And I don't think everybody will be able to comprehensively do like all of this stuff. And I think part of it too, I'll just say is like you see in the quotes, not over promising, right? I have hesitation of screening for tons of stuff if we don't have resources in place or a workflow in place to address it. I'd rather us not screen at UCSF if we don't have the bandwidth to respond to that, whether it's adjusted care or assistance. I would say let's keep working towards it, but not implement it until that's there because there's moral injury to people screening. There's certainly injury to the patients. So yeah, I guess I would say slow and steadily work in the local environment. Not a very satisfying answer. Sandrine.
Great talk. I think you should go to Dr. Fontel's.
Ooh, gosh. They let anybody on those Zooms, huh?
I won't disclose any of
the comments.
So maybe I didn't totally understand or catch this, but it seemed, and it's a little bit related to this last part of what you said about not screening if there's no resources. Because you showed how you can screen, and the hospitals that screen, and the hospitals that then connect to resources. But what I was missing a little, because that feels like if you just connect people to the resources, but to what degree are there just no resources?
Yeah, right. Especially like you look at the rural hospitals that can't do this, right?
Well,
yeah,
us with housing.
Totally right. So yeah, and this is where I do think, and we're having, not to get in operation logistics right now, but we're having this discussion on the operations committee about this now because there's some questions that people are really interested in implementing that we don't have resources for in San Francisco. But there is a lot we could do to adjust. So I think when I say responding to, I take response as either connecting to resources or adjusting something in care. So I do think if knowing housing does inform the care and how to do something, it's actually okay to screen for. I think part of it is the framing of, and I think part of it is us realizing like we do adjust things, and let's put it like, let's explicitly say what we're going to do differently when we know that this patient like doesn't have utilities at home. You know what I mean? And so, yeah. So I think when there aren't resources, if you can adjust thing, I think it's still justified. If you can't, then I would argue, it's this sort of social invasive thing that really we're starting to think now in some qualitative interviews might actually like harm patients. Like you asked me this and for what? Like why would I? Yeah. Does that kind of answer your question? Sorry. And did I repeat the question? Sandrine, for everybody, just sort of asked, what do we do if we don't have resources when we screen. So.
Right, I already told you there's an important person in the audience, and he has a question.
Oh boy.
Is any insurance company paying for screening? And given the evidence, is there any data on HMOs increasing social work?
Great question. Is that Bob? Okay, thanks, Dad. Great question.
You can't use no other opportunity to ask the question.
Right. Yeah. In terms of certain plans, I do know that there are certain like plan incentives, maybe like, for example, CalAIM in California is sort of payment reform that's allowing people for Medicaid populations to pay for sort of bundled services in community, including referrals to community-based like organizations for patients that have high risk. There's also, I mean, interesting. I don't know why I said that. So Kaiser, for example, they actually do a lot of this in some of their hospitals, and part of it is because I think they realize like how much it can. They're all about cost. Yeah, but they, I think a lot of people go right away to the social work resource, which I think is true, but I think there are other ways we can also build it too. I'm not just saying using referral platforms without CBOs, but even without social workers, if we have a connection with a community-based organization, or we have a way to respond with adjustment, or we have other things, we don't necessarily need that for some of the lighter touch social needs. Certainly for heavier touch social needs, social workers, absolutely. And that's what a lot of people are advocating for now. Yeah, Mindy.
There are issues with Kaiser, but I do think this reflects like they're the atypical model is when the insurance, the clinical care, and the act and the line,
right?
They all are working towards the same goal.
Right.
But actually, problem is in our or academic.
Right.
But,
right.
I mean, I'm just curious. Like education, to me is very interesting one in the TC that families found that to be the only one that's like, why are you asking me about this?
Yeah.
And then I started thinking like, why do I care?
Yeah.
And why do I screen? And also for the hospitals in the national study, like when they say they had an intervention to address education.
Yeah. Right.
Like,
right. Totally.
I don't even understand. I get conceptually how education doesn't help, but it just seems like a weird question.
Agree. I think where that came from. So Minnie was saying education seems kind of like a weird one in that some people in our pilot data, they weren't interested in that. Nationally, hospitals are saying they addressed it. I agree. First, I'll say again, national hospital studies, they're one person answering for everybody. So it's hard for me to think like I've actually been in some of these meetings for like US News and World Report for how we like answer these. And it's kind of like, it's not the most rigorous at times, figuring out. I imagine they probably meant like health literacy. I'm sure that's what I'm thinking is they probably were thinking, oh yeah, we ask patients about like if they can understand this before they want to check that box is my guess. It's interesting. I think education probably like if the history of looking at these like from a population health perspective or a pure like predictive and like perspective, education is probably the biggest one. You know what I mean? So I could see understanding like population health. I'd be like, that's the one thing that's most important. If you're asking me on the front line, like about that, I'm probably like, if you're talking about education resources, we asked about that too. Like, do you want help getting educated, like education? And there was like one, you know what I mean? So it was much lower. So I do think there are different, and that's kind of looking at the 5As. If you're talking about advocacy, education might be, or population health, like that might be a really helpful one. But if you're talking about like frontline, how you can adjust or address something, probably lower down. And I think for the patient reaction, my sense is that kind of like it goes to what bias will this have? Are they going to treat me differently if they know I'm this versus this? Yeah.
We're way over time. This is
sorry.
capturing captive you are.
Oh.
There are two more things on that I just have.
Yeah.
Like one is not a question, but David, I will have a like to share. Looking sharp, boss. And then there is
good evaluation for him.
From the same infamous Dr. Pantel.
Oh man.
Any studies on benefits of social workers making workarounds with team?
Oh, that's a good question, Dad. I think, I don't know. I can imagine on the pathway. So that study that I showed where you review social work notes and you're less likely to be readmitted, I'd imagine part of it is mediated by the presence of social workers on rounds, but I don't know of any studies. We're actually looking at studies now, looking at among social work notes, how many are written, what happens if they're written and not read, what happens if they're written and read. So more to come. I'll tell you next time we have dinner together.
Well, and hopefully next time you can come give grand rounds.
Whew. Wow, repeat.
Well, thanks so much.
Thanks so much.